There's a lot of self-indulgence that unfortunately exist in our community and others.
Let's make sure we are sharing. Let's make sure we are reaching out and letting people know. We're excited that we have Dr. Maurice Willis, Dr. Lindy Randall Hayes, Dr. Brian Robinson, Dr. Tamika Dawson, Dr. William James Hicks. Let's make sure we're sharing. These talented physicians are with us to share with us information we need about the social determinants of health and about the coronavirus and this Omicron variant.
Good day. I'm Jennifer Jones Austin, and I am excited for the opportunity to spend some time talking with five good doctors. I'm going to get a Black health booster, and so are you all as we listen to these doctors who are going to share with us all of the critical information that we need to know in order to take the best care of ourselves. So today I'm joined by Dr. Maurice Willis, Dr. Linda Randall Hayes, Dr. Brian Robinson, Dr. Tamika Dawson, and Dr. William James Hicks. And again, we're going to be getting a Black health booster. We're going to talk today about the Black health experience here in America. We're going to talk about, the disproportionalities when it comes to our health experiences and how we are, often more negatively impacted by certain health diseases, certain public health crises and challenges. We're going to talk about why that is. And then we're going to center on what we can do about it, how we can empower ourselves, empower our loved ones, empower our families, our communities. And then we're going to talk about this Omicron variant of the COVID-19 virus and how we need to do a better job of raising awareness and protecting ourselves. So let's jump right in. Again, we've got a panel of five experts who are going to share with us their knowledge and their wisdom and make sure that we are better informed and better prepared to care for ourselves when it comes to our health. Let's jump right on in. So there is this saying that when America catches a cold, Black people catch pneumonia. And essentially, what it's speaking to is how health challenges affect Black Americans disproportionately at an alarming rate, a negative rate. We can point to many different, many elements of medical and health data. And, we don't have to look far. We can look at the disproportionate rate of, cancers, how, Black men are, sometimes nearly twice as likely to be affected by colon cancer, how breast cancer disproportionately impacts Black women, how the infant and maternal mortality rate is 2 times for Black Americans than it is for white American women. And the list goes on and on. Obesity, diabetes, hypertension. The list goes on and on and on. And so we're going to talk about why that is, help us all to understand. And, I'm just going to encourage you all to just jump in. Help us to understand what we need to appreciate about some of these diseases. And let's center mainly on those that, have high morbidity rates. Talk to us about the diseases that Black Americans need to be most concerned about because of the higher mortality rates. Anybody want to jump in? I'll begin with Dr. Hayes.
Well, good evening, everyone. Thank you so much for this platform and this opportunity to share with our community some of the things that we are seeing as African American physicians. And I think you pretty much laid it all out there, right there on the line at the opening of this program. Because of the socioeconomic factors that African Americans are faced with, the economic disparities that we are faced with, it definitely is in parallel to the healthcare disparities that we see. And as we look at the physicians who are in our communities and taking care of us, we see sometimes, unfortunately, the perpetuation of those disparities. One of the things that I am very passionate about is actually training up the next generation of young physicians and young students and medical students, and even in middle school. Just recognizing and exposing young students to the sciences, to physics and biology and all of those things, and talking with them about what it means to take care of human beings. All of those things are going to be some of the things that we're going to need to invest in now in order to begin to nip away and break away at some of these disparities, because the more people and physicians and healthcare professionals that we have that look like us, the better off that we're going to be. And studies have shown that.
So, Dr. Randall Hayes, let me just ask you as a follow-up. In your practice, in your work, what are you seeing with respect to the health challenges that are presenting for Black Americans that concerns you most?
Well, let me just say, I'm Dr. Lindy Hayes, and I'm a board certified in emergency medicine. Starting out my training in Chicago and then in Washington, D.C., and now currently in the Indianapolis area and surrounding areas. What we are seeing in the emergency departments, in addition to the second part of our discussion tonight, in addition to COVID pneumonia and respiratory distress and failure, what we are also seeing is advanced stages of cancer presentations. We're seeing advanced stages of cardiac disease. We're seeing increase in presentations of various trauma. We're seeing lots and lots of acute mental health crises present in our emergency departments. And so all of these things have, again, you talk about the pneumonia that Black America receives in response to the cold that the rest of the nation has. We definitely see it in concentrated portions and in concentrated communities. And as our emergency departments fill, we are seeing all of those things that are presenting in larger numbers than we almost have the capacity to take care of.
And you, Dr. Robinson, are you seeing anything different?
No, we're seeing pretty much the exact same thing. And again, thank you for having me in this program. Just echoing off of what she said, we see a lot of these conditions in the hospital. They existed before COVID, of course. Excuse me. But COVID has made it just amplified so much more because access is a problem. People unable to get to their doctors, people not having appropriate screenings. We see so many people show up with conditions that should have been diagnosed long ago. Even basic hypertension, diabetes, and things are out of control. There's a lot of self-induced components that unfortunately exist in our community and others as well. And having people have the proper access and counseling to avoid some of those things is unfortunate. I think follow-up care has also been a big issue for many of our patients that we see. And again, all the social factors, which we deal with a lot in my hospital in particular, even basic getting rides to appointments, being able to afford medications, getting to the pharmacy. there's a lack of knowledge and medical literacy. Unfortunately, even if people do get care, sometimes it just doesn't come across as being as effective as we would like it to be.
Mm. And how about you, Dr. Dawson, with the family medical practice? Do the issues look different?
The issues are the exact same. It's very interesting. Dr. Robinson just brought up the best point of all, which is that we knew when COVID started that this was going to affect screening significantly. People weren't going into the hospital to get mammograms and colonoscopies, and that what we're seeing is advanced stages of some of these cancers. It's very difficult to get to their doctors right now. So for instance, if you ride the bus lines have kind of cut down on how many passengers can be on the bus. Secondary to COVID, everybody has to wear a mask. If you don't feel comfortable wearing a mask, you're not going to wear a mask. A lot of our community in general lives in food deserts where it's difficult for them to get food. And so the food that they're eating is unhealthy. So it's hard for them to go to the grocery store. So if you have diabetes and high blood pressure and you're buying things that are maybe not healthy for you because that's all that's available and close to you, that is definitely starting to affect our, prognosis. And so I think the biggest thing that Dr. Hayes was talking about is education is key, especially educating our young leaders in the medical field. I teach at the medical school here at Indiana University, and it's really important that we teach some of these socioeconomic issues because if their doctors understand and they know their patients aren't trying to purposely be non-compliant, which I think helps go a long way in trying to bridge some of the gaps that we see every day.
Mm-hmm. Thank you. Really appreciate that. Before we turn and just lean in a little bit more on the social determinants of health and the teachings and the education, I just want to quickly turn to you, Dr. Willis, to ask you, what are you seeing in your oncology practice?
Well, what I actually see is one health disparity building on another. Also see a lot of mistrust and distrust with the system in general, which leads to non-compliance. So if you have diabetes, it can make you immunocompromised, which gives you a higher risk of certain cancers like breast cancer and colorectal cancer. Mm-hmm. Not exercising, not eating correctly increases your chances of breast and colorectal cancer. And not getting screenings in time because of either access or mistrust or distrust of physicians. Mm-hmm. And, a great deal of my practice is trying to get our people to trust us as physicians again, because they've been through systems to where they're just looked at as numbers, not people, that, we're always labeled as non-compliant, mm-hmm. when they don't understand that they can't be compliant because they may not be able to afford things or may not have the transportation. So, the non-compliance is the easiest way to label someone and just toss them aside. You have to see why people have non-compliant issues. And, the health disparities and food deserts build to the ultimate where somebody has cancer, being deficient in vitamin D because they don't get outside and exercise builds on cancer. So the I did general internal medicine for 6 years before I did oncology. So I dealt with all those health disparities. I did National Health Service score in a small community. And the obesity, the non-exercise, the non-getting out, getting the vitamin D, the poor diets, I can just manage my diabetes by taking more insulin, which makes you gain more weight, mm-hmm. and leads to other problems. And health literacy is one thing, but the belief in the physician when they give you something that it's going to help you, or if you have a side effect from it, not calling the physician and say, hey, he just doesn't know what he's talking about, I'm not taking that medicine. We as Black people don't ask enough or the right questions from primary care all the way out through oncology. And we try to give them as much information to print out as we can because we're dealing with a deadly disease. But it is the relationship that you build with the patient that is the most important thing that creates trust, creates compliance. People want to know why all my patients show up on time. I say, I show up on time, and when they show up on time, I serve them on time. And you train patients. If you're a physician that always shows up late, your patient shows up late. So you build a trust with your actions, not just how good a physician you are, but how good a person you are. And a lot of people, we don't talk about the emotional intelligence of dealing with patients, and patients can sense whether you care about them or not. So that was a long answer for a short question.
I think it was a great answer. It was a long enough. It needed to be long. Let's lean in a little bit more to the social determinants of health. And then I want to pick up on how we talk and teach about them. So all of you alluded to, some with more specificity than others, the social determinants of health. I am an attorney and I center on policy with respect to structural and institutional racism and discrimination and economic insecurity and immobility. And often when we are looking at health and health disparities, there is this belief about that some would like to say that the black community doesn't take care of itself. Some of the health challenges that we have may be related to diet, but it's not simply because we necessarily eat more poorly or choose to, right? A social determinant is tied to the economics and the conditions of the environment in which you live. When I heard you speak, Dr. Willis, about, forgive me if I'm mistaken, but it was one of you, maybe it would have been Dr. Willis, but one of you injected this notion about race. And we're now leaning in more and more and appreciating that a lot of us are living with racialized trauma. And the relationships that have been created socially in our nation have kept many Black persons from feeling that they can have meaningful, robust dialogue and engagement with health professionals. They've been led to believe that they are in an inferior position. So when we think about the socioeconomic, we think about the lack of affordability of certain certain diets, how that is economic, but then we also think about the psyche. What do we do to educate? And I want to ask you, Dr. Hicks, appreciating your work, as a professor of medicine, how are we talking with the generations that are up and coming in the medical field about the connection, the intersection of race and poverty and socioeconomics with healthcare?
First of all, thank you for having me tonight. I guess I'm the oldest physician here, and I perhaps have an interesting perspective. I had some folks in my library at home the other day, and they looked at my picture of my internship class and my residency class at the University of Pittsburgh, and they noticed one person who looked like me, and that was me. So things have changed significantly, but we still need more folks that look like us taking care of us. And there's just no way around that. My experience has been kind of interesting in that for the first 22 years of my practice, it was a private practice. I enjoyed it. I had a great time, took care of wonderful patients and had great relationships with patients. And then the last 14 years, I was offered a professorship at Ohio State, and I took that position because in addition, I was offered the position of being co-director of diversity enhancement at Ohio State, James Cancer Hospital. And so we had a mission of making sure that we tried to take care of and appreciate all the social determinants of health that affected people's outcomes. Okay, and that was obviously a big deal to do. One of the other big things I did as an oncologist was making sure that people were aware of the fact that there were things called clinical trials that might afford them a better opportunity for a better outcome. So, obviously, to make that jump, I had to have something that really was significant for me to do. When I was at Ohio State, I was on the admissions committee, and that was a great position to be in as well. And we noticed an increase in the number of African American and Latino and Asian American and other minorities that were admitted to Ohio State. And I think that tradition has continued. But we certainly need to make sure that we as African American physicians teach our students what's necessary to try to make sure that we communicate with them so that we listen to them. My mother used to say, she'd say, if you're going to be a good doctor, you have to be a good listener. Mm. And, she had multiple myeloma, which is perhaps a disease that we'll talk about later. But as she, in the latter phases of her life, she sat me down and she just wanted to make sure that I understood what a good physician would look like. Mm. Not just that, I had the quote unquote book smarts, but that I was going to listen. And so for everybody who's here today, and is still seeing patients actively, that's a huge thing that can be done. And perhaps we'll see a change in the number of folks in the residency and internship classes.
I so appreciate your sharing all of that. And I'm just going to pick up on your last point about the doctor needing to listen, because very often when we talk about the health challenges that Black Americans experience, we center on their role and their responsibility in, taking care of themselves, but we don't center enough on the responsibility of the physician to the patient. And that's what you're doing in this moment. Help me to appreciate when you're engaging, all of you, when engaging with clients, patients, when engaging with people coming up in the medical profession, do you talk about preventable death? Do you, help to engage your patients, helping to develop their knowledge about what they can do to take better care of themselves? So are you engaging in just treatment? Do you center on prevention and prevention modalities? Dr. Hayes, you're on mute.
Thank you so much. I apologize. So interestingly, in the emergency department, we have to, of course, first we're treating. We have to treat very quickly. We have to listen very quickly, make our diagnosis, and begin to treat. However, simultaneously, what I have learned to do over my career and what I'm still learning to do is a lot of times we're able to we're getting to a place where we're allowing one other family member into the emergency department or things like that. But back before pandemic, we did have families were able to come back, the mother, the aunt, those folks who could contribute to what it is that I'm seeing in front of me. When we realize that, of course, again, in acute emergency situations, the patient is at one of the worst moments of their life. And so can they think of all of the symptoms that they've been having? Can they think of all the other things that has brought them to that moment? And oftentimes they cannot because they're in distress, either mentally or physically. So relying on the family members, the friends, big mama, god mama, whoever is there with that patient and able to help us to hear the unspoken. I think that's a lot of times what we have to do is be able to hear the unspoken and to take a look at those visual cues and those cultural cues that we as African Americans, we experience, and those things that we share. And we need to be proud and recognize that, when we even talking about meals, something as simple as if I see I'm in the emergency department and I see somebody is trying to, bring a certain meal out to the bedside of this patient that I'm treating for hypertension, right at that very moment, we say, no, we're not going to, no, we're going to, let's try something baked next time. Or, this is what you can try. It may be fast food, but it's less fattening, or it's less, less of a contributor to your high cholesterol, those kinds of things. But being able to look at those unspoken cues, being able to utilize anyone who might be there with that family. There's nothing worse that really irks me is seeing when a physician is, particularly in my field in either trauma or the emergency department, is unable to navigate the distress and the family or the loved ones who might be there with that patient. Oftentimes they can give you more information to help you get onto a road of proper diagnosis and treatment and prayerfully, hopefully subsequent recovery than you could in excluding those family members or excluding those loved ones. So just trying to bring everyone, as many as possible, right? Because we're in a space where we can't have as many people in the, in the patient's room at the bedside like we used to, but trying to utilize everyone that we possibly can to be able to hear, like Dr. said, to be able to hear even the unspoken of what the patient is trying to tell us.
Very interesting. Dr. Willis, in your practice, as you are, caring for women, women who are, pregnant, are you seeing that they're coming in with a greater awareness than in years past about the experience of Black women? Are you engaging with them in preventive measures to make sure that they can have the best pregnancies possible? Like what's happening?
I think you addressed her. I do cancer. I don't treat women.
Oh, it's I'm thinking gynecology, oncology. And forgive me, how embarrassed am I, especially as somebody who had cancer. So let's talk a little bit then about oncology. Yeah. Forgive me. And I actually had acute myeloid leukemia and had a acute myeloid leukemia that presented with a broken chromosome, causing me to have be in need of a bone marrow transplant that I actually ultimately didn't secure and wound up having a cord blood transplant. Had to go through several clinical trials and then had a stem cell transplant. But let's talk then about cancer. And let's talk about the disproportionalities that we see in terms of, certain types of cancer. Do you see greater knowledge, greater awareness? Do you see people who are taking control of the disease sooner rather than later? Or are they coming in with a woe is me death sentence and not really engaging?
So I have an interesting perspective on all of that because we have the biggest prison system in Texas that we take care of, the Texas Department of Corrections. So we take care of all the prisoners in the state of Texas with cancer. I also see regular patients also. So, when you're dealing with Texas Department of Corrections, you have a lot more Black and Latino patients. So I get to see, a great deal of the disparities. Also, here in Galveston, Houston area, there's a big Black population and Latino population. The problems, not the problems, but let me just give you a comparison of the average Caucasian patient that walks into my office. The average Caucasian patient that walks in my office has a loved one with them and a list of questions, usually from 1 to 20. And they've already looked up their cancer, looked up possible treatments, possible side effects. So when I go through what we're going to do, how we're going to do it, give them the literature on our treatment, they're nodding their heads because, like, yeah, I read about that already. That sounds like a viable treatment. Whereas a Black or Latino patient comes in, they're usually by themselves. They don't want their family to know they have cancer because they got enough on them. They don't want to worry them. So when you're giving them all the information, they're so traumatized by hearing that they have cancer, that they have a limited time that they may be living, or all the treatment that they have to go through. They don't hear half what you have to say.
Mm-hmm.
So you have to reiterate several times of what their diagnosis is, what their prognosis is, what the side effects of the treatment are, and you just have to know what you're dealing with. Unfortunately, if you're not a minority physician and understand the people, because you've gone through, you have loved ones or you've seen other people, friends go through this, you might not understand the unspoken language, and you can say, hey, do you really understand what we're talking about? Do you really understand what we're doing?
Mm-hmm.
Do you trust what we're doing? Do you need more information? And when you're dealing with other physicians, they're busy and they may not see the unspoken word and just label as the patient as non-compliant. And preventive care, I don't see it as much with my Latino and African American patients. And I'm not giving them an excuse, but a lot of times they're just trying to pay their bills and live. But you do have some that are well educated and still have bad habits. And they can do better, and you cannot chastise them. You just have to really try to work with them to educate them on the best way to take care of things, where it's not sometimes what you say is how you say it. And a lot of times our patients and our population may be turned off by physicians, and we can all have a bad day, whether you're Black, white, green, or yellow, may be turned off by how the physician has approached them. And, it's some of the stuff we can't avoid, like heredity. You can't avoid the fact that you have sickle cell, but you can avoid passing it to the next generation by choosing your mate more wisely. But we don't talk about things like that. We just don't talk about the difficult things in our community with each other. Now, you had AML, and I'm sure that with a lot. I have did you share this with your kids or your family? Because I have patients. I have a breast cancer patient that has college kids grown and refused to share that with them. And that's going to hurt the next generation because,
Yeah.
In 15, 20 years from now, they are at risk to have breast cancer. If they never knew their mother had breast cancer, they will not be as vigilant. And so they're going to fall in the same situation because we are too prideful and we want to protect everybody. I had a stage 4 lung cancer patient that did not tell his children or his best friends he had cancer. He had lung cancer for 9 years, a remarkable life, but didn't tell anybody he had cancer until he was in his last month of life. And we have to stop being so secretive because it comes back to bite us.
Right. Well, I'll tell you very quickly that in my case, I told the world. And I told the world mainly because I needed a bone marrow transplant and I needed a donor. 3 full-blooded siblings, and not one of them were a match for me. And we had to turn to the National Bone Marrow Registry and had to find someone with similar genetic typing. And so we essentially put the word out. The way that my cancer presented, I woke up on a Friday morning with a flu-like fever and was triaged at one of the best hospitals in New York City less than 12 hours later and was told that I had a run-of-the-mill virus, to take some Advil and go home and sleep it off. And 2 days later, I woke up and I was blind and couldn't see. And we knew it wasn't a run-of-the-mill virus. And literally, 2 days later, after being admitted to the hospital and a series of tests that were expedited, I was fortunate, learned I had acute myeloid leukemia. And 2 days after that, I lay in a coma, my husband being told that I had a 1% chance of death that weekend because the cancer was moving throughout my body. And so we moved and told anybody and everybody. I had a 7-year-old and a 12-year-old, and we told them. And I'm glad you asked that question, because one of the things that I learned is that not only when you tell people, do you perhaps get greater information and greater connection to resources, and you prepare the next generation, but it also can help your mental health and your coping, because you're not fighting alone. When we first opened up, I believe it was Dr. Hayes who talked about mental health issues that are presenting. And I want to take a few minutes to just talk about mental health, because for so long here in America, we've centered on healthcare and we've separated mental health from healthcare. And in the Black community, we have stigmatized mental health challenges. And so, I'm going to begin with you, Dr. Robinson, and I'd love for you, Dr. Dawson, to weigh in, and also to hear from you, Dr. Hicks. What are we seeing right now when you are attending to patients, Dr. Robinson, in the hospital? Do you see people presenting with mental health challenges? Dr. Dawson, we're hearing a lot about, families, young persons, old persons, especially during COVID, suffering with depression, being disconnected. What are you seeing with respect to these issues? And what are you doing?
It's been terrible. I do all inpatient care. So by the time people are meeting me, something has unfortunately gone drastically wrong, which also points toward morbidity, which you brought up at the top. A lot of mental health problems. We actually have a psych ward at our hospital, which is frequently full. My team frequently sees some of those patients as well. So your more mundane issues, depression, anxiety, have been way up. In our ER, and I'm sure Dr. Hayes sees as well, a lot of people come in with depression, come in with suicide attempts, suicide gestures. We see that a lot of dysfunction as well, people just trying to get along in their day-to-day lives. In Indianapolis and a lot of places, it also relates to a lot of substance abuse, which is way up. Our EMS runs for drug overdoses and whatnot has doubled during the COVID days. And in addition to that, your more hardcore psychiatric diagnosis, your people with schizophrenia and schizoaffective disorder, again, having difficult times getting their medicines, staying on track, getting the proper therapies and treatments has been a major challenge for us as well.
Wow. Dr. Dawson?
I think one of the hardest things that I've seen is just, especially during these 2 COVID years that we've certainly had, is the isolation of our elderly patients and the fact that they cannot be around loved ones and talk to them. And so their depression rates have gone significantly up. And with that has come a whole bunch of morbidity and mortality, and the fact that they don't take their medicines. They're super depressed. They are not getting the help or the care that they need. Their families do not realize that they may be deteriorating at home. And so that's been really hard. It's also really difficult because right now there's so many people who are depressed and anxious in general. And our mental health partners are really struggling to get people in. And so there's a huge access issue. And so, I'm treating way more depression and anxiety than I'm used to, because they can't get in with a psychologist. They can't get in with a counselor. They cannot get in with a psychiatrist. And that has definitely hindered care. We are just overworked and overburdened, and to the point that they're struggling, and we're trying the best to help them. And I think I tell all patients to try your primary care doctor first, because you may not be able to get into a psychiatrist for 6 months, but there is something we can do to help, at least to start that process.
And tell me, are you seeing a greater mental health greater mental health challenges for young persons. I mean, we're hearing a lot about Black teenagers experiencing suicidal ideation at a higher rate than we'd seen before. Are you seeing this? Is it really playing out? Whether it's
Every
suicide?
day.
Oh,
Every day, I see at least once a week a child that has considered suicide, whether that be from isolation, bullying on social media, just feeling the trauma of day to day life. And so it's really difficult to try to make sure you're taking the best care of them as humanly possible. And I'm sure Dr. Hayes sees this a lot in her emergency room as these young teens are coming in and they're struggling with what's going on.
Dr. Hayes, do you want to speak to that?
Yes, it definitely is the case, and we are having to really try to utilize some creative ways to get, particularly in this moment as we talk about the mental health of our young people, utilizing various community services, community groups, social groups, different boys and girls clubs, because again, sometimes the wait to get into a psychiatrist is extraordinary. And so we have got to utilize a primary doctors in terms of being able to begin some of those basic medications that can help these students, but really beginning to utilize our community support. One of the things that I love to have in my pockets when I'm seeing patients in the emergency department, I kind of have my resources. So, whose phone number can I give? Can I give, my colleagues, Dr. such and so, or this doctor, that doctor, or counselor, psychiatrist, anyone that I have come in contact with over the years that that is kind and compassionate and will kind of go above and beyond to try to get patients in. I keep their information. I keep their phone numbers. I tack it up on the wall at my workstation so that so we can actually navigate through the difficult time we are having with access. We are really having a difficult time with access. We're not able necessarily to get the access in the straight, streamlined ways that we have previously been able to do so because of limitations in the doctor's office's space and again, just the time to get appointments and so on and so forth. So yes, but we are really trying to be resourceful with what we have and really trying to, if it takes me, keeping a young student in our emergency department, 2 or 3 shifts before I can get him or her some help, then that is unfortunately what I'm going to do. And so we, again, I think one of the things that we need to do as Black physicians is increase our collaboration and partnerships and, being able to, dial on the phone really quickly and really just try to try to help navigate some of our patients a little bit more efficiently. And, again, that's, something that, especially as we talk about training up this next group of young African-American, medical professionals, how to get them to engage and collaborate and to be resourceful so that we can try to get our patients what they need.
And I really appreciate your sharing that. And I want to turn to Dr. Hicks to ask you, as we talk about training up the next generation of medical professionals, is there more centering on the relationship, the intersectionality of health with mental health? How if you are struggling mentally, how that can impact your physical well-being. Is there attention being paid to that? Are doctors being trained in that way?
Yes, they are for the most part. Physicians are being made to understand the relationship of the psyche and the physical nature of our beings. One of the things that it's kind of interesting, I'll just bring it up now. Since I retired a few years ago, one of the things I've done is called locum tenens work. Okay. And I've been all over the South southeastern United States as well as the Midwest. And one of the things that I've noticed is the difference in quality of care depending on where you are and who you're seeing. And, you know, it's a tough situation to be in. I was recently in a fairly large metropolitan area in the southeastern United States. And, you know, I was really concerned that the quality of care really wasn't what I thought it should be. And yet you have to walk a narrow pathway to make sure you sort of tell the patient, well, you might want to make sure you get a second opinion about what's going on here. But that's something that's real too.
Indeed. Indeed. And I'm also thinking about, you mentioned, you know, you speak to geographical differences. If I'm remembering correctly, Dr. Willis, you touched upon, care for justice-involved persons, and that's an area and a group of people who often are left out of the conversation, and we don't lean in and look at and appreciate their acute mental and physical health needs. Is there anything that you can add to the conversation about, you know, that about that community? And, you know, for Black Americans, we need to be concerned. Those are our brothers and sisters.
Well, you know, a great deal of my patients, the reason they're in the facility in jail is because they don't have the ability to exist in society in our societal norms, which may be, and most of the time, is a personality disorder or a mental health issue that has not been addressed. And, you know, in our community, if you're crazy, you just don't deal with, you know, our crazy uncle or auntie, they locked in a room, or they're not allowed in the house, they're a thug, they're a criminal. We don't ever address the mental health issues. You know, my saddest case right now is I'm treating a 17-year-old kid who's in an adult prison, who has been in prison since he was 14. He's got schizophrenia, had a schizophrenic break, and committed a crime. And he's in prison with adults, hardened criminals, 17-year-old kid, and tried as an adult. If you don't have good representation or money, you're just going to get pled or, you know, just thrown in jail. And I'm not saying by any means a great deal of these people may be innocent. They just didn't get the reasonable doubt. And then they have criminal record, they get out, they hadn't paid a bill ever, you know, and they don't know how to exist in society, work and pay a light bill or a phone bill. That seems simple to us, but if you brought 2 meals a day, the lights are on, and all you have to do is make sure you don't get beat up or raped, that's how your day goes. And make sure you get something to eat. You don't have to worry about, you know, getting up, going to work on time, unless you have a job in the prison where they pay you $2, where a skilled laborer would get $20. And what we don't realize is, guys, we have a plantation behind bars, and slavery is not over.
Oh, I agree. I've served for several years here in New York City on the Board of Correction. And it looks like, you know, our jails look like modern day slavery, with the distinction that there's no skills building going on. And, you know, in many of our jails and prisons across the country, we have more people with mental health issues in our jails and prisons than we have in the mental health facilities and institutions that exist here in America. It's an ever-growing problem, and a lot of it is racialized. So let's talk about. Let's shift a little. We've articulated many of the ever-presenting challenges. I want to talk for a minute about, what do what when engaging with your patients, wherever you may meet them, find them, when engaging with people who are coming up in the profession, with your colleagues, what, could you all speak to what are the, if you will, kind of like the guiding principles? What are the, if you're talking to individuals and families, and you understand that they are grappling with many of these social conditions, that it's not so easy for them to go and just get the best medical care, pay for the best medical care possible, or they are challenged on their job, which does not allow them, to take the best care of themselves. What are the golden rules, if you will? How do you engage with them? What are the basics that you want Black Americans to know and appreciate? Just the core things that they need to be doing to take the best care possible of themselves. Dr. Dawson?
I think the first thing I tell my patients and my medical students especially is, I think Dr. Hicks hit it on the nail on the head, is you have to listen. And so I already have a blueprint of when you're coming in. If you're coming in for your diabetes follow-up, my mind is already thinking about your A1C and do we need to change your medicine? But the first question I ask my patient is not, oh, you're coming in for a follow-up for your diabetes. My first question is, what brings you in today? Because my agenda is to do your diabetes, but your agenda may be something different. And when I say that, immediately that gives my patients ownership of the visit so that they can come in with their concerns. And the diabetes will be taken care of because it's on my agenda. But the first thing we need to take care of is what's on yours. And I tell patients to come in with a list, especially when they have cancer. When I tell a patient, hey, we got this mammogram, it looks like it's cancer, I bring them in to talk to them about it before they ever see an oncologist. So I can tell them, you need to take a family member with you and you need to ask as many questions that you can, and you need to write them down because you're not going to remember this later. And so I try to empower them to take some ownership into their healthcare so that they have the power to feel like, hey, I can ask these questions. I can do this. I can go into this doctor's office and feel like I'm going to get the care that I deserve. And I always say, if you don't feel like you're getting the care you deserve, Dr. Hitz also said, you can always get a second opinion. I have a patient right now who's going to MD Anderson because they feel like their colon cancer isn't being taken care of here in Indianapolis. That is something that you are empowered to do. And I try to give them as much power as possible, because if they feel empowered, they're going to take better care of themselves.
Thank you. Dr. Robinson, you say, when you're seeing people, they're in crisis. So, where do you begin with them to give them a sense that, to Dr. Dawson's point, they have ownership, they have agency?
We do a lot of things. So first of all, listening is key. And luckily, when you're in the hospital, we have a lot more time to really sit down with them and eke out a lot of the problems that they're experiencing. We try to reach out and see if they have a patient advocate, such as a family member or friend, and strongly encourage that. We have an electronic patient portal, as many places do now, and we strongly recommend people sign up for that because they can look and see all their results and whatnot, and even notes to be directly involved in their care. And now there's actually a law passed that it's coming in real time. I'll have people hospitalized and they'll know their results before I do. So that also engages them and makes them feel a part of their care. We have a very important multidisciplinary team, and we just make sure that they understand that we are there to help them. So after they've met me and their case manager and the social worker and the physical therapist, and we sit down, we narrow that agenda. and that was a very interesting comment Dr. Dawson made. There's actually research done that says if you look at what the doctor is worried about and what the patient are worried about, sometimes you have two completely different lists. So you have to make sure you hit all of those things and have a true bidirectional relationship and conversations with your patients. And sometimes I'll just ask them, what's most important to you? If there's anything we could do for you at all, what is it? And sometimes it's some of the most simple, basic things like, oh, well, that's easy. That's a phone call that makes your life so much easier. So where we work, we just try to have a strong culture as well of caring and making 100% sure people know that we're there for them and they can always come to us and rely on our service. So,
Excellent. Dr. Willis?
Well, my favorite saying is, meet the patient where they are. And that's exactly what these other physicians have said. I went in to see a patient yesterday, and the MA says, the patient's grumpy. I don't know what kind of interaction you're going to have. So I brought in everything that I had planned to show him about the chemotherapy, his diagnosis, the plan. And all he wanted to talk about, this poor man was crying, is that he really hasn't recovered from his surgery for his cancer. He can't eat. He's losing weight. He's in pain. And I didn't even talk about anything that I do. I met him where he was and said, these are things we need to do to improve your nutrition. These are the things we need to do to improve your pain. And I'll get back to my agenda on the next visit, because you can't go through chemotherapy not having these things addressed. So, it could have been addressed somewhere else and maybe should have been addressed somewhere else. It seen another physician a couple of days ago, but you have to be willing to change your agenda for your patient and where they are. You have to meet them where they are.
Wow. Dr. Hayes, I imagine your experience is somewhat different because you're in the ER. They're not necessarily patients that you're seeing on a regular basis. Is that correct?
Yes, that is correct. But one of the things that I try to make sure that I approach each patient with is, and I had a patient to ask me this when I was a medical student, actually. She asked me, she said, she had a question about her mom's care. She said, you love your mom, right? I said, yes, I love my mom with all my heart. She said, if my mom were your mom, what would you do? And one of the things that I try to always approach the patient from the standpoint of, if this were my loved one, what is it that I would do? How would I approach this patient? How aggressive or not would I be with this patient? What are the types of tests and things that I would order for this patient? And I find that when I approach the patient with that same sense, everyone I approach the same. And I think one of the things that that has really stood out to me in terms of some of this medical students and even residents that have been kind of crossing our paths is we want to make sure that they do not fall into stereotyping patients. Because the moment you stereotype a patient based on what they look or what kind of bag they have on the nightstand or all of these things, you're going to miss something. You're going to miss whether it's child abuse, whether is this a patient who's being sex trafficked or what else is going on with this patient. You have to try to delve deeper and really look for the emergency, because I only get one chance. And I think that's in terms of some of the differences, I get the one chance to try to find the thing that this patient's at a crossroads right in my emergency department. What is it that I can do? How can I approach this patient? I feel that I can approach them with the utmost in compassion, treating them like I would treat my own family member, and basically having a list, kind of having a pathway in front of me that everyone goes down the same path. We talk about, clinical criteria and, clinically indicated, and why do we do certain things? We don't do things because of our preconceived notions and biases, which is like a doctor talked about, how we're teaching these young students coming behind us is realize that you have biases, but if you don't go by kind of the book and go by science and go by how we're taught and trained to approach, human beings, that is how you miss things. And from the patient standpoint, I want them to know that you and I, we got one shot together. Tell it all. You get a chance to tell me whatever it is that you need to tell me right now. This person that's in the room with you, do I need to have them to step out so that you can be free to say what it is that you need to say, or say what it is that you're experiencing? So I need to give them, everything that I can in that brief moment in time. And then vice versa, I need to open up the door so they can feel the same.
As I listen to all of you, I'm reminded of, I shared with you all that I had cancer. And it was a harrowing experience, and everybody's experience with cancer is challenging. But, mine was an ordeal, the likes of which I've got oncologists at Memorial Sloan Kettering that are still writing papers 11 years about it, and having me move around the country and actually beyond with them to talk about my journey. One of the things that I remember is when learning that my siblings were not a match, and meeting the so-called #1 leukemia specialist in New York City. She looked at me. I didn't know if I was going to get a bone marrow transplant. And I'll never forget this woman, who not of the same race as me, not of the same religion, not in the same, age bracket, but she looked at me and she said, "You have a daughter that is the same age as my son. I have and then she said, you have a son she said, you have a daughter, same age as my son. You have a son, same age as my daughter." She said, "I am going to move heaven and earth to find you a transplant because you are going to live." And there was something about that doctor in that moment, despite what the odds were, who looked at me and said, I'm not letting you go. We're going to fight this together. That gave me hope. She saw me. She didn't just see like the dire situation I was in. She saw that I needed hope and I needed someone to fight with me. And that's what I'm hearing, that you all seek to do with your patients. Dr. Hicks,
Yes.
based on what you've heard, what more can you add to this? I know you've got a lot.
Well, I'm glad you asked. One, as I mentioned earlier, when I went to Ohio State, I accepted the challenge of being co-director of diversity enhancement. And as a part of that, we had an emphasis on clinical trials and making sure that everybody was given enough information about their disease, and given that in a manner that they could understand. Now, in addition, what we did was we started a radio program every Saturday morning called It's All About Health. Okay. Every Saturday morning. And I would bring on specialists in various cancer fields, and we would educate our audience. And one of the things that I did was to make sure that my co-host was a local pastor. Okay? Because I'm a preacher's kid myself, and I know how important pastors are in the community. It was an overwhelming success, so that we were able to document that many times, people were not terribly frightened when they faced a diagnosis of cancer, because they had heard some of the programs that we were able to bring to them. So I really enjoyed that aspect of that responsibility. So that's broadening it a little bit. not just dealing with individual patients, which is important, of course, but to bring it to the community. Wow.
Absolutely, absolutely. And when you, especially with Black community, when you tie in the faith connect, it can make a world of a difference. You know, we've got about, I don't know, maybe about another 10 minutes. And you all have provided so much food for thought. And I'm sure that those who are leaning in and listening will be so enriched by what you've had to share. I intentionally and deliberately decided that we weren't going to spend our entire time talking about Omicron and COVID-19 because it has already consumed so much, right, of our daily lives. The stresses abound. But we do need to talk for just a few more minutes about COVID-19 and these variants. It seems like they are ever coming. I read on social media, somebody said, can we get everybody vaccinated so we don't have to go through the entire Greek alphabet? Right? It's proving to be too much. But let's just talk about Omicron for a moment. Let's talk about the vaccine. Let's talk about the booster. Let's talk about whether or not, COVID-19 is here to stay. So let's jump in and begin with the continuing vaccine hesitancy, and especially for persons of color around the country. Even in the jails and prisons, we see that, where, we should be concerned about very often densely populated areas, hesitation can abound and can put people at risk. But there are people who are saying, I've survived this long, I'm going to be all right. If it hasn't got me yet, I'm going to be okay. What do you say to that? Do you think they're right? Or do you think that they need to get the vaccine?
I think they've been very lucky and they need to get the vaccine and the booster. And my personal opinion, I have no basis of fact or science to back this up. I'm concerned that we will need to have ongoing boosters as time goes on. That's just my personal opinion.
More along the lines of like the annual flu shot.
Exactly. Yeah. It really, I really think that's what's going to happen. And the bottom line here is that we're not going to be able to do anything with the 18% or 20% of people who are never vaxxers. We're just not. But those folks are the people who are in the intensive care units now. Those folks are the folks that are on the respirators now. So, I hate to say this, but if you ask for something and you get it, then you shouldn't be surprised.
I think that's,
if I may,
please.
the vaccines are safe. People were waiting for to see what happens, quote unquote. Well, there's no long-term side effects from these vaccinations, but there are long-term side effects from getting COVID. People were concerned with how fast they were made, but they were being developed with SARS and MERS and just never came to fruition because those viruses kind of fizzled out. But the technology is top notch. This is one of the safest and most high-tech vaccines we've ever had. The variants, it's easy to tweak the technology to make new ones. The research has clearly shown that people vaccinated do better even than people with natural infections because they have higher antibody levels. And that's what's protecting you from getting severely ill. In our hospital, our numbers are up again. We've had maybe 3 people that were vaccinated that ended up in ICU, maybe 3 to 4. Everybody else is unvaccinated. The people that are getting severely ill are. I think some of the statistics as well are a little bit confusing. If you get COVID, the odds of dying are relatively low for an individual, but there's still somewhere between 1 to 2, no more than 3%. But when you're dealing with millions of people getting a highly contagious virus is when you start having, going on 750,000 people dead in America for COVID-related illness, which we definitely want to avoid. And lastly, of course, in my realm, the hospitals are full. We have about 40 COVID patients in the hospital. And in many hospitals, those beds are full, and it's hard for us to provide other services. So even though you may not get COVID, you might need us for something else. And our capabilities are stretched at the moment.
Mm-hmm. And what I'm hearing now is that whereas before they were saying that you should not mix vaccines, first and second dose. Is the research changing? Is the science changing now and indicating that it's okay to get a booster of a type different than the original vaccine type that you received? I mean, what can you tell us about that? Because I'm sure that there will be an abundance of myths about whether or not that's right or that's wrong. And so what can you tell us?
That is right. You can do that. If I may jump in, I actually, and I share this with my patients, I got Moderna, my first 2 shots, and then when I got my booster, I got Pfizer. And the other things I share with my patients is that I have personally, now I have, like Dr. Hicks, I also, in addition to working in emergency departments locally, I also did worked with a company that contracted with the Army Corps of Engineers throughout this pandemic and set up field hospitals filled with COVID patients across the country. So I was in 2 convention centers in Washington, D.C., 2 convention centers in Detroit, was in Los Angeles, San Diego, and had basically makeshift hospitals at convention centers throughout. And I tell people I have never intubated a patient that was vaccinated. Every single patient that I personally have ever intubated, and it's been many since this all began, I have never intubated a vaccinated patient and never had to. And that typically hits home with a lot of folks that I have that come to the emergency department who are teetering about it. But of course, by the time they get to us in the emergency department, I tell them you are not eligible at this time to be vaccinated. Okay, we will attempt to get you monoclonal antibodies and treat you and do some other things, but you are not eligible for the vaccine right at this moment. But you can get, if you've got a different vaccine initially, you can mix even if you had, Johnson & Johnson, I know some of my colleagues have had Johnson & Johnson and then did go on to get Moderna or Pfizer, but the vaccine is safe. There was a report, actually it just came out today. I want to say it was a hospital either in Connecticut or Massachusetts that every 100%, usually we have been going through the pandemic saying, 98% of the people in the hospital are the unvaccinated. Well, they have 100, they said every single solitary one of their COVID patients was an unvaccinated patient. Not even one was vaccinated. And so this is getting to the point where this is a disease of the unvaccinated primarily. And that's how we really need to teach and talk to our patients about this. This is a disease of the unvaccinated. So, choose ye this day is pretty much where we need to go with this. So, so I continually try to, talk to my patients and try to convince them and give them the real life information. I personally, on a very personal note, and just drop this on to share with people. My very best childhood girlfriend, I was maid of honor in her wedding and she was maid of honor in mine. She had a lot of questions around the vaccine and we talked about it many months. She contracted COVID, did not let anyone know. We talk about people having diseases, especially long chronic diseases, and not telling their family members. There's a sense of shame or not wanting to worry them. Anyhow, she died of COVID in 7 days and not vaccinated, 52 years old, beautiful children, grandchildren. So that was personally the closest that hit home for me. That was the closest person to my own personal life that I lost to COVID. And I share that with patients because I tell them, and this was just in October. So we've been going through this since last March. So I tell people, COVID will find you. It will find you and you need to be prepared. So it took all this time, and it wasn't until this October that I lost one of my closest and dearest friends to COVID-19. So we even just each one reach one, we just share the messages often and as much as we can.
Absolutely. Thank you. So
Anybody, if I may,
we've got
anybody
about-
who has COVID or thinks you have COVID, please come see us. We can
Yeah.
treat you. Please don't avoid us if you think you have COVID.
absolutely. And let me just add to that. So we're in flu season now. And you know, people are going to their physicians and getting a flu shot, and the COVID boosters being, you know, provided them, or the initial first or second dose. Should they be taking both together? I've heard, you know, that it's not a problem, but I've also heard people saying that they've been laid out afterward, that, you know, a shot in one arm and in the other arm, you know, in the same visit is just, you know, like just wreaking havoc on their bodies. Any last minute recommendations on that, because we're about to close on out?
A series of one myself, I had no problems.
Okay. Doing both.
I
It is
second
safe,
that.
but you might not feel that great.
Good deal. And one last thing. Even if you are fully vaccinated, and today that means not just, you know, the first 2 doses, but with the booster, should we still be wearing our masks? Can we go to
Absolutely.
church?
Yes.
You know, should we be eating inside, indoors? Like, is it okay?
If you can ask people for their cards at the door.
It's one thing we
Do it.
don't. Yeah, we I think that's one of the big things that it has been something we've been tiptoeing over, is should vaccines be required at a lot of our functions that we have, our galas and our meetings, and I won't go into specifics, and even our churches. How do we navigate, you know, requesting that persons be vaccinated to attend? One thing that we can do is partner along with a pharmacy and have vaccinations available in your church. My home church in Chicago, that's what they do every Sunday, is have vaccines available. But until we address that, our vaccines required in our venues, we must be masked.
Yeah. Well,
You can
I
you
share
can still
with you
have a
all.
mild illness from COVID, so that means your infectivity and your contagiousness is less, but it's not zero. So you can still spread it to multiple vaccinated people who just have a mild cold from it, and then it's going to hit somebody unvaccinated and make them sick. So
Well, I'll just quickly share with you. I live in New York, and about the only place you can go in New York City and not be vaccinated is to church. And you better go in there and pray that you get some religion and get a vaccine. We are out of time. I just want to tell you, I had a very long day. And I had a 3-hour meeting centered on racial justice here in New York City, and showed up to this conversation excited about it. But I'm going to tell you, I feel invigorated. I feel reinvigorated. You all have enriched my knowledge, and I am certain that that those who are leaning in and listening will feel the same. I thank you so much for this evening's conversation, and more significantly, I thank you for the work that you each and every one of you are doing in our community to make all of us healthy and safe. Have a good evening.
You too. Thank you.
Thank you.